This is Module 6, Part 2, Lecture Part 2. So, we made it through the muscles of the head and face last time, and we are introducing this morning the muscles of the anterior chest and abdominal wall. So, and I'm in the middle of page 3 of your notes. That's where they are. So, the deltoid muscle, you see it there, and you're familiar with it, I'm sure, packs 3 different functions into one muscle. So it flexes the arm, it adducts the arm, and extends the arm back to the anatomical position. So interesting and very important muscle, and you see it there labeled to the right of the figure there on page 163. So the pectoralis major adducts, flexes, and rotates the arm medially towards the trunk. So, and obviously you're familiar with the pectoralis major muscle. The pectoralis minor is inferior to the pectoralis major. It elevates the ribs and depresses the scapula. The major muscles of the abdominal wall flex and rotate the vertebral column and compress the abdomen. So you gotta have it when you want to vomit, all right? As well as defecate and urinate, and in terms of childbirth. So important functions, not necessarily ones that we talk a lot about. So look at the linea alba. That is an introduction to these muscles, incidentally. So the linea alba is a white line of connective tissue that starts near the end of the sternum and runs through the navel to the pubis, and that binds all of the abdominal muscles. So that's connective tissue in terms of this, not muscle itself. So there's the rectus abdominis muscle. It's a straight muscle covered by a sheath of connective tissue that flexes the vertebral column, and you see the rectus abdominis pointed to there. The external oblique, on both sides, the external obliques, you see them, they flex and rotate the vertebral column. The internal oblique flexes and rotates the vertebral column, but simply lies deeper to the external oblique. Again, you see it depicted there in an attempt to show the layers. And then the transverse abdominis compresses the abdomen, and it is deeper even to the internal oblique, and you see it depicted as well. So those are the major muscles of the anterior chest and the abdominal wall. So if you would, turn over to the muscles of the shoulder and the upper arm. So figure 6.6 on page 165 is what we'll start with. Notice the trapezius that is, of course, depicted on the posterior view. To the left, it's the large shoulder muscle, and it extends up the neck to the shoulder and down the thoracic vertebra. It extends and laterally flexes the head. So, when you give your mom, what have you been doing? No. That's what you're doing. You're using your trapezius, all right? It elevates and depresses and retracts the scapula. So that's, of course, what we're doing there. It's not that I have a bunch of children that I've ever seen that, or that I wasn't a kid myself. The latissimus dorsi muscle works opposite to the deltoid to adduct the arm, brings the arm that is pointing away from the trunk back to the anatomical position, immediately and extending and rotating the arm in the rowing fashion. So in terms of the rowing thing there. So, and again, you see the latissimus dorsi, those large muscles to both sides. Turn over to the next page, or well, actually on the back page of page 3 of your notes. In terms of the teres major, it is depicted there in the middle shot of figure 6.6, and it works with the latissimus dorsi to adduct, extend, and medially rotate the arm. The rhomboides major and the rhomboides minor, so you see both of them depicted top and bottom in terms of where they're pointing. But they work with the elevator scapulae muscle, the trapezius, the serratus anterior, and the pectoralis minor to move and stabilize the scapula. So again, we mentioned last time the fact that most actions include the effort of a variety of muscles. And so there's an excellent example for you. The triceps brachii muscle works to extend the forearm at the elbow. So again, you see the triceps there depicted in the figure 6.6. And the shoulder joint, the ball and socket, is actually rather shallow, and it allows maximum range of motion. Because ligaments reduce the range of motion in a joint, the ball of the humerus is held into the socket of the scapula actually by muscle tension provided by 4 different muscles. The supranatus muscle, the infraspinatus muscle, the teres minor, and the subscapularis provide shoulder joint security, and combined, those things are known as the rotator cuff muscles. Damage to one or more of these muscles is very common in a lot of sports. So in terms of, if you hear, or you, I pray not, but if you're diagnosed with rotator cuff issues, you know, it could be any of those 4 muscles. And of course, in terms of their tensile strength, these things decrease as you age. And that combined with wear on the cartilage that forms inside of these joints can make for very difficult times. I've got no less than, well, 2 different folks, family or friends, who are right now looking at shoulder surgery, and it's not a fun surgery, I can tell you that, but in any respect. So that's description there of the ball and socket in terms of it all. The major muscles of the upper arm, well, we just looked at that. I didn't refer you to figure 6.7. I should have, in terms of the trapezius and the subscapularis and those other muscles that we referred to in terms of this shoulder. So interesting in terms of it all. Turn over to the next page and we'll start with the major muscles of the forearm. The anterior view. So the biceps brachii, the very first muscle referred to there in the depiction, flexes the forearm at the elbow. So of course that's the making a muscle, you know, that's the showing off muscle in terms of the biceps. The brachioradialis and the pronator teres help the biceps brachii in flexing the forearm. The pronator teres and the pronator quadratus are involved in pronation, in other words, palms down of the forearm at the elbow. So again, you see the brachioradialis there as well as the pronator teres. And the pronator quadratus, that is, let's see, that's depicted on the bottom illustration. The supinator supinates, that's above and front, if you'll recall, the forearm. The biceps brachii helps in this function. So opening a tight jar lid, since the supinator and biceps brachii work to supinate, again, that's up and front, left-handed people open jars much more easily than right-handed people, just instinctively. So you handed a jar. Which hand do you use to open that thing? Yeah. Left? Right? Do you really? You turn like this to open the jar?
I use my right hand.
Say what?
I use my right hand to turn it.
Okay, gotcha.
I'm a righty.
You're a left-hander or a righty?
A righty.
You're a righty? All right, that's interesting. Anybody else? As it turns out, the reason why lefties are more able to open jars is that is their side, their strength, and the action this way as opposed to the action this way is usually easier to, I mean, and again, if you get it open, it don't matter how you do it. We use our teeth for crying out loud, but in any regards, this is usually easier based on the action of these muscles than this. So try it sometime, or notice it sometime. When your mom hands you the jar and says, I can't get this open. Yeah, let me show you here. All right, so.
If I just run this in hot water.
There you go. Or smack it on the side or something like that.
Get a nice.
Yeah, exactly. All right, so the flexor carpi radialis is depicted there in the middle of the bottom, and it flexes and abducts the wrist. The flexor carpi ulnaris is also depicted on the bottom, but to the right. It also flexes the wrist and acts as an antagonist to the flexor carpi radialis, adducting the wrist. In other words, in the anatomical position, and adducting the wrist brings the little fingers together. Hitchhiking thumb is adducting the wrist as well. All right. Palmaris longus also flexes the wrist. The extensor carpi radialis longus is the posterior forearm extends the wrist and is antagonist to the flexor carpi radialis, the flexor carpi ulnaris, and the palmaris longus. So again, those bones are depicted for you both in the above illustration and below. And you get a sense, even just looking at them in terms of the illustrations, how that works in terms of this and the various actions. The extensor digitorum extends the wrists and the forefingers and is antagonist of the flexor digitorum superficialis, and the extensor retinaculum is the bracelet of dense regular connective tissue that winds around the wrist, covering the extensor tendons, holding the tendons down as the muscles work. The extensor tendons would bow out otherwise, and so I wanted you to note that in terms of it. Extensor reticulum, where, let's see what they got here. Okay, yeah, sorry about that. Turn over to page 168. Better view there in terms of the posterior view. So, number of muscles that we've just pointed out, but notice especially the extensor retinaculum in terms of its sort of braceleting all of those tendons, again, so they do not bow out and you know, you lose function in terms of that. I'll just skip it. Let's just move on. Talking muscles here. Look at the muscles of the hand. and then they do not have a separate depiction there, but the muscles of the hand are delicate yet strong. The hand gets its strength from its cable operation of the muscles of the forearm. In other words, the cables are long, thin tendons that are visible when you make the cat claw. So you see them things sticking out in your hand when you do that number. And that is what is providing you both the dexterity and the strength in terms of your hands. The extrinsic hand muscles are the muscles in the forearm which create motion in the hands, and the intrinsic hand muscles are muscles within the hand that create motion in the hand. And so in terms of the intrinsic muscles, there's a whole bunch of them, and we're not going to try to cover them all. But one of the things that you can grasp from the idea of the intrinsic hand muscles is that is what's providing you the dexterity in terms of the fine motor action necessary for you to accomplish things and lots of things. So I guess I should stop there. I mean, this stuff, in terms of learning it, it just is what it is what we've said all along. And then relating the muscles in this instance, and it's the way it is with all of anatomy and physiology, but relating the pictures of the muscles, the anatomy, to the descriptions of their action in this instance in terms of the muscles. That's what I'm hoping for you to grasp. Look at the pictures. Draw the pictures. I mean, some of them are quite detailed, so maybe that's not an easy thing for you to do. But to be familiar with the pictures and relate them to, we don't have as many pages of notes this time. There's a lot. I mean, there's just a lot. But in any respect, relating the pictures to the descriptions of these things. Well, there are nice pretty pictures of the muscles of the thigh. So both lateral and posterior in terms of figure 6.10. So the gluteus maximus, you see it depicted there from the lateral and the posterior view. It extends, it abducts, and laterally rotates the thigh. Very important, obviously, to running. And you know that if you've ever tweaked that thing, you're not going to be running very far or very long. The gluteus medius is deep to the gluteus maximus, and you see it's right in the middle there in terms of the name, but it is depicted as being below the gluteus maximus. It adducts and medially rotates the thigh. Medicine is commonly injected into this particular muscle. So it moves past the maximus and into the medius. That's where, if you're gonna get your shot in the keister, that's where it's going, okay, into that particular muscle. The gluteus minimus abducts and also medially rotates the thigh, and that is, I think that was depicted too, was it not? Gluteus minimus is on the bottom, so you see it more clearly, but again, deep to the gluteus medius, to the left there on the bottom. So the biceps femoris and the semimembranous and the semitendinosus, that was actually the semimembranosus and the semitendinosus are known as the hamstring. They flex the leg and extend the thigh. So you see those depicted on the posterior view in terms of that of those three. Once again, if you have if it's known as pulling a hamstring, if you've ever done that, if you've tweaked your hamstring, you know where they're at. Oh my. A number of Father's Days ago, I bet it's probably 8 or 9 now, so I was in my early 50s, and I used to be fast. Once upon a time. My son couldn't possibly believe that, but there was once upon a time I was. And so I have son-in-laws that are competitive, and so we decided we were going to race around the backyard. And so I hadn't run and I hadn't warmed up in quite a while, but I decided, well, I'm going to do this thing. So I took off and took probably 8 or 9 steps when, for the first time in my life, I tweaked. I pulled pretty good, strained one of those muscles, and I can tell you that was quite the experience, and not one that I'd ever want to repeat. And I trust any of you who have pulled that know what I mean. The whole thing was black and blue, and it was that way for a while. So, oh my goodness gracious! But anyway, that kind of messed up that Father's Day. So look at the anterior view then, in terms of this. That's on page 171, and you see the iliacus and the pros major. They flex the thigh. They have the same insertion and work through the same motion, and are often considered one muscle known as the iliopsis. These muscles do the work of sit-ups, and their origin are in the posterior abdominal wall on the lumbar vertebra and ilium, and insert into a process on the proximal end of the femur. So if you're sitting for long periods of time, that causes these muscles to shorten, and that is at least one of the reasons for backaches from time to time. If you're not up and around, you feel the result of the shortening of those muscles. And then the other way to experience or to feel those muscles is the fencer position. It stretches them, as a matter of fact, and helps them relieve the back strain. So I don't even do it. I guess it's like this. That's right. There you go. So that's it. We need to erase that off the video. The rectus femoris, the vastus lateralis, the vastus intermedium, the vastus medialis are grouped together as the quadriceps femoris. All of their insertions are on a process of the tibia, and they extend the leg, that is the lower leg. The rectus femoris flexes the thigh. So again, in terms of these various depictions here, the vastus lateralis, the vastus medialis, you see them depicted. The sartorius is the longest muscle in the body, and it flexes and laterally rotates the thigh and flexes the leg. So if you sit Indian style, that's all 3 of these actions. And so in terms of the sartorius, it's depicted in both views. You see that long, thin muscle there. The tensor fasciae latae flexes the thigh and adducts and medially rotates the thigh. The adductor longus and adductor magnus work together to adduct the thigh. These muscles are the ones that hurt when you ride horses if you're not used to that. If you haven't stretched and or strengthened those particular muscles a little while after you've ridden a horse, you know which ones those were. So that's those muscles. They also rotate the thigh laterally. The adductor longus flexes the thigh, and the adductor magnus extends the thigh. So again, you see the adductor longus there, as well as the adductor magnus there, depicted in the middle top of the figures. The gracilis adducts the thigh and flexes the leg, and so the gracilis there, in terms of the middle depiction on the bottom, that long, thin muscle. One more page, and we're gonna finish early today, and that's a good thing for all of us. I need to give you your stuff back and check homework. It was a long day in chemistry today. So the major muscles of the leg, of the lower leg, if you look at page 173. So the gastrocnemius and the soleus form the bulge on the posterior of the leg. We call it the calf. They both plantar flex the foot, in other words, stand you on your tippy toes. The gastrocnemius flexes the leg. These muscles insert into the calcaneus, that's the heel bone, via the calcaneal, I don't know why I'm struggling with that today, calcaneal tendon, which of course is the Achilles tendon. So again, you see those depicted in terms of the soleus on the bottom, as well as the gastrocnemius, and you see that long depiction of the calcaneal tendon, the Achilles tendon there, from mid-calf all the way to the heel. The tibialis anterior works to dorsiflex, or lift up and invert or turn inward the foot, and the tibialis anterior is depicted on the lateral view there, in terms of the right. You can feel that by moving as well. The peroneus longus and the peroneus brevis are muscles that evert the foot against the tibialis anterior. They're especially active when you're walking on your toes. That's plantar flexing the feet. So the perioneus are depicted there in the bottom on both drawings there, the perioneus longus and the peroneus brevis. The flexor digitorum longus flexes the four lateral toes. That's what curls your toes. And then the extensor digitorum longus is antagonist to that, extending the four lateral toes. The extensor reticula is the dense, regular connective tissue that keeps the tendons from bowing out. Again, we looked at that in terms of to compare back to page 168 in terms of the extensor retinaculum there. It does the same function in the foot as it does in the hand. The extensor hallucis longus dorsiflex and inverts the foot and extends the big toe. The patellar ligament extends from the patella. That's the muscle that doctors seat you on the edge of the table and then tap on for the test for reflexes in terms of whether or not you are receiving the necessary stimuli from your nervous system. I think I've told this story, but my daughter had a syndrome. It is Guillain-Barré, and that is a syndrome produced by the body itself in response to some virus. It is an immune response, overactive immune response, in which the body actually attacks the synapses of nerves throughout your body. And slowly but surely, you lose the ability to move, at least efficiently, and then to move at all, your extremities, and depending on how bad it gets, oddly enough, it's rarely fatal, but depending on how bad it gets, it can affect all the way to the point of the heart and the lungs. So some people have to be hospitalized in order to treat that. But she was sick, and one doctor in the practice couldn't figure it out. And then her regular doctor was finally in and thought it was still a reaction to some kind of bacteria. She was on antibiotics. And and sent us home, and all of a sudden we get a call from him, and he says, I'd like to come out to your house and look at her one more time. And he drives out and sits her on the couch and performed what we just described in terms of tapping on that patellar ligament. And there was no movement. There was nothing. And he said, I want you to put her in the car and take her to the hospital right now. And so that man had managed to figure out what was going on. It was Guillain-Barré. And so she did. She got worse in the hospital, but of course got better. But interesting process there. Well, that's what I got. And we finished early. This is almost a miracle. How can this be?